Hi, this is Scott Ellis. I'm a foot and ankle orthopedic surgeon at the Hospital for Special Surgery in New York, and I'm about to do a Lapidus procedure on a patient who has a isolated bunion. Her toes drift a little bit invalgus, you'll note through the case, but the bunion is the primary problem. She does not have hammer toes. So what we're going to do is correct the bunion through a first tarsal metatarsal fusion. And I'm going to show you a plate and screw construct that really help hold the bone over and down and compress on the bottom. There's a chance for me also to do a incision between the first and second toes, a web space incision if I feel like I need to release it, a chance for an Akin osteotomy at the end, and you'll probably see calcaneal bone graft. The whole goal here is to correct the bunion, correct rotation or pronation, and have it heal in a corrected position where this bunion doesn't come back. So I hope you learn a lot from the video.
I generally start with the medial eminence excision first. You don't have to. It's a longitudinal incision. I'm going to look for this dorsal nerve. There's often a vessel with it so that I can keep it dorsal. The capsulotomy will essentially or eventually be longitudinal for me as well. And I do this in all cases to shave off a little of that bone because it's painful and prominent, although I tell patients the most important it's the realignment and not so much the shaving. I'll have cauterize some small vessels here as well. And again, look for that dorsal nerve. I tend to like to mark myself out a line where I'm going to follow the capsulotomy, and you have to stay a little high because the metatarsal, as you come proximally, is dorsal, and if you're not careful, you'll be on the bottom side of it, which is not good. So I'll stay high, and my goal approximately is to be in the middle of the shaft. I generally come through full thickness in this capsule here. Be a little careful distally around the metatarsal head because there's some cartilage there. Right there, I am just exposing the capsule off the proximal phalanx, but more proximally, I want to take the tissue as a single layer. This layer, again, I'm going to repair at the end of the case because it's going to help me pull those sesamoids even a little bit further over. I don't rely on it to get the sesamoids. It's the metatarsal correction, but it helps a little bit at the end. So here's me taking the medial eminence. I do it in line with the shaft. Usually I start about 2 millimeters medial to the sulcus and just gently come down. So I'm going to line up with the shaft. It's always a good idea, I find, to take a little less bone than you think and then make a small second pass so you don't notch into the shaft. There I wasn't even close, but you want a nice smooth surface. The next incision I make is over the top of the first TMT joint. Sometimes I'll do the web space incision first. In this case, I wasn't sure whether I would really need it to get those sesamoids over, so I started dorsal, but more often I'll start distal. I open the capsule, move branches of the superficial perineal nerve, generally laterally, and then I score the bone with that electrocautery, which serves two purposes. One, it helps me identify the capsule to start this capsular exposure, but also it leaves a mark on the bone. So later I know from a perspective of rotation how much I'm rotating or supinating the foot. I put a laminar spreader in there and gently with an Lambot osteotome, I'll open the capsule below to give myself more opening. I then take the cartilage off either side of the joint with a combination of curette and a osteotome. I then take a flat saw cut on each side. I start on the metatarsal. I really try to go square. It's really important to take minimal bone. Do not take more dorsal than plantar because you do not want to elevate it. Notice I have a laminar, I have a point of reduction clamp distally that my assistant is using to distract out the bone, giving me just enough space to make that cut. I prefer to do the cut freehand as opposed to using cutting guides because I have more control and I can take much smaller amounts of bone and more precise bone. On the cuneiform side, which we didn't show there, I take a little wedge. There's a little laterally based wedge. Here's what it looks like when it comes out. You can see more wide on the lateral side versus the medial, but not a big wedge at all. If you take a big wedge, you're going to shorten and also get transferred to two. And you, again, do not want to dorsiflex. Once I'm happy with my cut, I'll then put a laminar spreader in. I'm going to prepare the lateral side of the joint and then ultimately put some drill holes in on each side. So in this case, I'm just taking a little electrocautery, and on the base of the second metatarsal, which is just adjacent, I'm just taking off some of the periosteum and other tissue there because I want to give myself space to be able to translate the base of that medial first metatarsal over. It doesn't necessarily correct the IM angle, but really helps get the metatarsal over to the point where it helps, I believe, the IM angle. I'm taking a little bone off, also just a tiny bit with a small osteotome off the base of the second, and oftentimes, not shown here, I'll take the saw and take just a small sliver off the base of the first metatarsal as well. Once I'm happy with how I'm going to be able to reduce that bone, I'll fenestrate each side of the joint with a 1.6 K wire, usually starting at the bottom and then just going all around and on top. I have my assistant do the same on the cuneiform side. We'll do both medially and laterally. This is all, I believe, to help get this bone to heal, ultimately when it's fixed together. I'll start some provisional K-wires that are going to be ultimately out of the way for my fixation for the cross screw and plate. But I start the first one from the cuneiform from proximal to distal. The second one's going to be in the opposite direction. Notice how I'm starting pretty lateral there, and I'm staying superficial. That is because I want to stay away from a cross screw that's coming up. This is demineralized bone matrix that I can't tell you is actually the end all be all to get the bone to heal, but I believe it helps. I have not shown the reduction mover there, but I will pin the metatarsal in place in the correct rotation with respect to the cuneiform on each side. And then once I'm happy there, I go distally to do a provisional suture in the capsule. I have not taken any capsule out at this point. I take a pretty generous bite in the middle because what I'm trying to do is bring those sesamoids over just a little bit more to make myself sure that I have the bone in a correct position. And if so, I will proceed on to fix the metatarsal or the TMT joint more proximally. Here's us just tying down that suture. And again, I'm going to go later, take a little capsule out in general, and most often use non-absorbable sutures. This is a vehicle just for some provisional fixation. Clinically, the foot looks pretty good. Generally, I'll take an x-ray there to see if I'm happy with the sesamoid position. And it's got to be a simulated AP. The toe looks like it's coming a little bit closer to the second than I'd like. But the IM angle looked pretty good there. And because of it, I'm going to start doing my definitive fixation. So the first wire that goes with the set that I use actually comes from the base of the metatarsal, and I stay a little bit on the plantar side, and I'm going to pass it across the TMT joint, in the first TMT joint, that is, and into the middle cuneiform. So ironically, it is actually going to be going across the inner cuneiform junction. You can see we've taken a number of x-rays. Sometimes it takes multiple attempts to get this wire just right, but it's so important. Its job is also to stay slightly plantar because by staying plantar, I'm going to compress the bottom of the joint, and that is so important to keep that first metatarsal down, and I think so key to healing in this procedure. It's really helped me with my union rates. So just slowly passing that wire across. We're using x-ray as we go. You can see there it comes into the middle cuneiform. And I'm going to ultimately drive it just up to the edge of the cuneiform, just about in the corner pocket, so to speak, of where the navicular meets that middle cuneiform, or the second cuneiform. That looks pretty good on that view. I generally will take a lateral view also because I want to make sure I'm not either too high or too low on that metatarsal. There it is there. Depending on how you take that x-ray, it can change a little bit. I can see I have a nice apposition on my TMT joint. The wire is probably starting a little more dorsal than I want, but is parallel to the metatarsal and in general pretty good. I think in general I would keep it just a little more plantar than that view. But and they're showing maybe even a better lateral view, and it looks pretty good there. So once I'm happy, and that's the biggest key, I think, to this procedure, I'm going to measure the depth of the indirect depth gauge, which I have not shown. I drill to just less than that depth with this cannulated drill. If you run into those other cross wires that I provisionally put in, you can make slight adjustments by putting in a new one and just taking the old one out. It's so key, though, to keep those because it's holding the reduction that I've tried so hard to get. Here's the screw coming across. I put a washer on it too because that gives me some extra surface area on the plantar medial aspect of that first metatarsal, so I can compress. I use a little clamp to get the washer under the skin so it doesn't pinch the skin. Just be gentle with that. Then once the washer gets underneath, I'll lift up the other side to see how I'm doing in terms of bringing the washer down. You want to feel for a good fit or tight bite, compression. I'll look on an x-ray also, make sure I'm not too far on either side. That head looks like it still needs to go in just a little bit more. I don't want to be in the navicular cuneiform joint. It looks like it's a little bit close, but that's pretty good. Once I'm happy with that, there's the plate that I use. It is a locking plate with an oblong hole. It has two proximal locking screws that go in the cuneiform, an oblong compression slot distally, and then two more locking screws distally. This is what it looks like when it's pinned on with an olive wire distally, and I actually just pin through the guide proximally. I'll start putting in the screws. The first two screws proximally are done generally through locking towers. I know the relative lengths in general of these screws, but the bottom plantar one there is generally about 14 millimeters, maybe 16. The top's more like 28. It's really important, I find, to aim in both cases away from the middle cuneiform. If you actually go into the middle cuneiform a little bit, it's okay. What you don't want to do is go into the second TMT joint. This is the locking screw. In other words, it actually locks into the plate itself. It goes proximal. I'll get that down, not tighten it completely until I have my second one. I drilled the second one already. It needs to aim generally a little bit medially, again, away from the second TMT and cuneiform. That's why I'm using a freer to kind of hold it there. This is the oblong screw that we just put distally. It goes eccentrically. It's a cortical screw now. After I drilled it just on the distal side of that hole, which will compress the plate. And then finally, when I'm happy, I'll lock the proximal two screws. These are done generally through a locking tower. And again, they are locking into the first metatarsal. Notice I've taken out one of my provisional K-wires, the one from distal to proximal. Generally, I'll leave that, but in this case, it's in the way. So I needed to take it out. Here's what it looks like. Nice IM angle correction. The crossing screws are just a tad bit long, but not bad. And good apposition of the joint. The crossing screw is nicely proximal. Now, I will go back. I'll take out that provisional vicryl suture that I had, and I'm going to generally take out a little bit of the capsule because I want to tighten it some. So here's me. I have an assistant hold on one end with a tweezer or pickup. The tissue I hold on the other, and I'll take a millimeter or two, depending on how much redundancy there is of the capsule. Sometimes I don't need to take any. If there's a huge bunion correction and they have a very redundant capsule, it'll be a little bit more. But this is generally about how much I take. I've got a Raytech or sponge in the first web space that's holding the toe over. It's relaxing that capsule a little bit. And then that allows me to more easily, definitively close that capsule. This is a generally an absorbable suture. In this case, it's a 2-0 fiber wire that I'm using to place around and do figure of 8 in generally 3 areas. And I'll tie those down, cinch it down so I can get the sesamoids over a little bit more. You cannot, as I said before, and generally rely on this, because if your sesamoids aren't just about in the right position, this is not going to get in there. It's just to fine tune it just a little bit. There, I'm tying it. In general, I will cut this with a knife. It actually is a little bit hard to cut, so I want a nice smooth cut and not compromise the suture, the repair that I just performed. There's a very nice view. Sesamoids are completely over. IM angle looks perfectly straight compared to the second, so real happy with that result. Now I'm deciding whether I need to bring the big toe over a little bit more with an Akin osteotomy, which is an osteotomy through the base of the proximal phalanx. In this case, it looks like I didn't need to do it. So I'm going to calcaneal bone graft. I do that Akin just to bring it just a little bit over, but you do not rely on the Akin for your bunion correction. It's just, again, fine tuning it. On the lateral side of the heel, I make a small incision. This is a 4-0 drill sleeve, which I use just manually to go in and get a little core of calcaneal bone graft. There's commercially available devices as well. I find that this works just fine. I then close this with a little portal stitch. It is a horizontal mattress stitch in that case. Not shown here, but I take a 5mm burr and just at the joint, and just medial to that plate, I'll go in about 5mm to make a small trough. That's where I put my calcaneal bone graft. Now, this is called stress strain relief. The idea is there's going to be a little micromotion along the periphery of that joint, and by putting in a little space with the burr, I can allow for a little bit more micromotion, and I fill it with bone graft to allow it to heal. Now, you got to be real careful because the deep perineal and dorsalis pedis, the nerve and vessels, respectively, are there on the lateral side, so protect those. But in general, I'll try to close this periosteum or capsule over the top of the plate, just so the plate won't be as prominent. I do with figure 8 vicryl. There's a number of cases where this layer is quite thin and you don't have a great layer to begin with. I find if you start a little bit more medial at the beginning of the case, it gives you a slightly better chance. And there I am doing it naked. So I generally will do that before the calcaneal bone graft, but also just depends. What it looks like, just don't leave the operating room until you're convinced. I extend essentially that medial eminence incision distally. Again, watch for the nerves because they will continue distally. Although it's not uncommon for a patient to have a little patch of numbness there, but I'm going to dissect on the bottom and top, respectively, of the proximal phalanx. I'm going to want to do so to be able to put some homins in there on each side. There's a homin that's going on the bottom, one that's going to go on the top. I'm going to put a guide wire across to help guide my osteotomy that I'll then check on an x-ray. I generally do fix this with a staple. So in that case, I'm doing a transverse osteotomy. If you're fixing with a screw, I think probably a better idea to go slightly oblique because you from distal to proximal because you want your screw to be a little more parallel. This is me putting the wire in across. I'll again check with an x-ray. Here it is. That one's aiming a little proximal. Often if I see that, I'll make a slight adjustment and head a little distal, which I have there. And then I'm really happy with that. So I'll cut that wire short, and generally I will cut on the distal end of it. The width of that bone about in that area is generally about 8 millimeters, maybe slightly more. So I'll actually mark my saw. If there's a mark there, it's about 8 millimeters and go just shy. I'm just making sure I cut dorsal and proximal. I have to leave a cortex laterally because that's how this is stable. Once I'm across, I'll just use a plier. That wire comes out quite easily. This is key. This is a very small osteotomy, and you want to be perfectly parallel to your other one. So I'll actually kind of go in my cut and then go completely parallel, just taking a millimeter or so of bone. I start parallel and just gently turn my hand to aim towards the other cut so that I can then bring it over. You see how now it's moving and it's coming over. This osteotomy actually is pretty easy to get into trouble because you destabilize it and then you have an issue trying to fix it. I will hold it provisionally with a K-wire. You start just at the proximal aspect of that proximal phalanx, which tends to be right distal to that suture. And then I'm going to come across the osteotomy with my wire. Once I've fixed it provisionally, I need it to be stable. This one looks like there's still a little instability in it. So I'm probably going to just close it manually there. And then I have my assistant with an 8 millimeter staple drill through the staple guide. You're going to drill on both sides. It's real important to stay a little bit dorsal on this bone because it has more bone dorsal and you can slip off the bottom surface. Now, I don't think it matters whether you cut distal or proximal first. There's a little, you generally don't go across the other cortex. There's these little pins that you put through the guide that will hold them because you need to maintain that relationship. So we drilled the proximal hole first and put a little pin. You can put a pin distally. It doesn't really matter because you can see the hole there, and that's where you're going to put the staple. So you can see the whole distal. We're going to take out the pin proximal. You can see the whole proximal. That's where the staple is going to go. It's an 8 millimeter staple I use. You can use 7, 9 around that area. You gently tap the staple in. It doesn't go all the way in initially. There'll be a final impaction here. So it's nice and firm. I find a staple a pretty easy way to do it. Now we're impacting it in position. There we go. So again, that Akin osteotomy, just to fine tune it just a little bit. And there it is. So very nice reduction of the IM angle. Sesamoids look pretty good. And then the fine tuning of the Akin looks excellent. So now we've turned the tourniquet down. I'll spend some time if there's some small bleeding vessels, particularly those right below the skin, to cauterize those, and then we'll start closing. So the combination I use is a monocryl buried for my subcutaneous closure, and most commonly a running nylon for the skin itself. notice I had the web space incision marked out. I never used it. So I'd say now in about half the cases, I don't use that web space incision anymore. It does lead to a little bit more stiffness, I find, a little more discomfort for a while. It eventually goes away. However, if you're not getting the sesamoids over, you have to, my experience, you have to make that. Some people will actually do it through the medial incision itself. I don't find that I can see what I need to see. So I do it here. This is a running nylon stitch, and that's how I close the rest.
I hope you enjoyed the video. I think the take-homes from that video is that we performed the Lapidus procedure with the screw and plate construct. Some unique challenges of that case were that the toes were drifting over a little to the side, and it's really hard in my experience to correct those, so I just left that little drift. I did do an Akin osteotomy in the end to bring the big toe over slightly more, but the key to that correction was taking the right amount of bone cuts and controlling rotation. You saw the little electric cautery lines where I could more or less see what my rotation was, and we had good fixation to get that bone to heal. She will be not putting weight on the foot for 4 weeks. I'll then progress her weight over 4. I'm actually going to put her in a boot at 2 and then start physical therapy about 4 weeks. So it will take a while to heal. We've gone a lot quicker in terms of weight bearing now with this plate and screw construct as opposed to just 2 cross screws, but it's been really helpful in my practice. I'm confident based on that surgery she's going to do well, and her bunion pain will be gone and have that first metatarsal staple. So I hope you learned a lot.